Hello, Dr. Madison. Thank you for joining us. And I'm looking forward to hearing you talk about what you do as a neurointerventional surgeon and about why you started your company, Thanacare, which offers patients and caregivers an opportunity to plan for their health in advance. Let's start with you trained as a neurointerventional surgeon, and can you tell us a little bit about that work and what are the moments that you experienced in your work that inspired you to start Thanacare?
Great. Okay. Again, thank you for the opportunity. And yes, as a neurointerventional surgeon, I basically spend my time treating patients primarily with stroke and brain aneurysm. I use endovascular techniques to do so, catheter systems. And with regards to stroke, we're generally doing an intervention to try to open up a vessel at the base of the brain in the setting of an acute stroke that would otherwise potentially threaten that patient's life or leave them in a nursing home. And it was in that patient population that I saw this glaring need to prepare for end of life that we don't do really a very good job with currently. The result of that lack of preparation then led most of the families who were making decisions for that patient to choose more care, even if it didn't really make sense in the sense of trying to make that patient live longer or better. Again, if we ever have an opportunity as a healthcare provider to do an intervention to help somebody live longer or better, we're very much in favor of that. That's our job. But we also see, notably towards end of life, that sometimes we're delivering care that really doesn't meet that threshold, that it doesn't make that patient live longer or better. And it is that situation that we should be trying to avoid through preparation and speaking about it with our families and making plans ahead of time so that we don't get that unnecessary care that we would probably choose not to get if we were able to make decisions for ourselves and if those decisions were made ahead of time.
To clarify, your patients may be in the hospital and you're called to help them, or how does that work?
Yes, I'm a hospital-based physician, so the procedures that I do on patients are always done in the hospital. And for me, the classic example is that I get called to the hospital to potentially do a stroke intervention on, for example, an 88-year-old female who is in a long-term care facility who's been diagnosed with dementia and has moderate dementia and is in a memory care unit. Well, she no longer can make decisions for herself. Most stroke patients can't. Her family, unfortunately, the reality is often, despite the fact that she's 88 and in a memory care unit, her family's had no discussions about what kind of care she wants towards end of life. And again, what ends up happening is that the family often they don't want to be burdened with the guilt of making the decision not to provide care to mom or grandma. And so they invariably, almost invariably say, yes, let's do it anyway. I explained to them, well, in this situation, the best that we can hope for is that she returns to her pre-existing status, which was a dementia patient, and then goes back to the memory care unit and is of dementia. And in all honesty, that's one of the worst ways to die. And prolonging that life under these circumstances may or may not make sense. But invariably, because they haven't thought about it or planned for it, and they don't want the guilt and responsibility of making those decisions, and they're not been guided to make those decisions by her when she was younger and healthier and able to make those decisions for herself, that care gets delivered. I end up doing that stroke intervention. And one of the things that has stimulated me to want to do this was that I've heard so many of those patients' family members calling back afterwards, 6 months later, 8 months later, and just say, hey, Dr. Madison, wish we would have listened to you because what we're going through now is terrible and, it potentially avoidable.
Do you find those conversations difficult to have?
In the absence of any planning, sometimes because these types of conversations really could not be taking place in an emergency setting. The best time to think about and prepare for your end of life experience is when you are quote unquote younger and healthier and able to make your own decisions. That's when you are able to make the decisions that what kind of care do you want at end of life? What kind of experience do you want at end of life? And how can you guide your family towards those decisions and help them make those decisions by putting down, and documenting what you want done. And if you do that, then they are able to do what you would like to have done in the absence of you being able to make those decisions, and avoid the guilt and the responsibility and the turmoil and the trauma associated with trying to fight their way through those decisions without your help. And so, in an emergency situation, it's so much more stressful and it just is so much more suboptimal. And currently that's where most of these conversations are taking place. A patient shows up in the hospital, they have a life-threatening condition, they have no preparation for that end-of-life experience. No advanced care planning documentation has been done. They've not defined who are going to make their decisions for them in the absence of them being able to make those decisions. And it's a lot messier and it's a lot more dysfunctional than it needs to be. It's a long-winded answer, but I would just say when you have the documents done and when the patients and the families know what they want to have done and it's all very clearly documented, then the decisions are not really all that difficult. They're certainly much less difficult than when that has not been done ahead of time.
I'm glad you explained that it's best to not wait until people have a crisis. When should people be thinking about planning ahead? And how do we overcome the fear of thinking about what could happen?
Well, there's a big hill to climb because in this country, only a small percentage of patients and their families have done this or gone through this exercise. I think the primary reasons for that are multifactorial, but certainly a fear of death is one of the biggest concerns. And we all want to live. We all want to live as well and as long as we can. And none of us really, love to think about our death necessarily. But I do think that once people realize that it's a part of our life experience, our end of life experience is part of our life experience. It's the last thing you'll do on this globe or this earth. And again, I think that once we get clarity among the population about the fact that not doing so is so damaging and results in so much difficulty, I think we will break through. I can't say that we've broken through yet, but I would say that when you focus on the fact that most patients don't want to die in a hospital, they would prefer to, once they get to that point, die outside of the hospital, presumably at home if possible, but certainly outside the hospital surrounded by their family and friends. And during COVID, we saw this. I mean, patients were dying alone in ICUs. It was tragic. And I think that most of us work hard to build a family and a cohesive family. It's not always easy to build and maintain those relationships. And what we often see at end of life is that in the absence of this planning, these family units that we spend our life fostering good relationships with can often be brought into conflict with each other over what to do about mom or dad. And brothers and sisters, after these end of life experiences with mom or dad, sometimes they don't talk to each other, which is never what anybody would have wanted. I think that the other thing that's now becoming so much more clear is that how much of our precious financial resources we're spending, our family's precious financial resources we're spending at end of life on care that may not make sense. People work hard their entire lives to try to build a form of a nest egg, and most of the time they'd like that to be, they think about that ahead of time as going to their spouse or their children, and they make a will to define that the assets would do so. And there's much less resistance against that. What we are seeing now is that so much of the time when you don't make these decisions ahead of time, that all of this money is spent on care and the family ends up spending all those resources on that care. The family member or their estate might be bankrupt at the time of the conclusion of their life. And And again, it's like, first of all, when you're alive and able to make your own decisions, you get to make those decisions. That's your right. And nobody's ever going to question that. It's just that when you no longer can decide what you want to have done under certain circumstances for your care delivery, whenever that happens, and you've not helped the person, not only have you not made the decision about who's making that decision for you, either your spouse or your children typically, but you also have not given them any guidance as to what you want done or don't want done, then you put a tremendous burden on them that is unnecessary and I think is not works for the majority of people, the majority of families in our country at this point in time.
In thinking about my training as a resident chaplain, I can remember moments where we had no paperwork, thinking about whether to resuscitate a patient when we were doing more harm than good, and family members couldn't find the directions or did not have any. So I can appreciate what Thanacare offers for people in thinking ahead of time rather than waiting for a moment of crisis. Having said that, you've created Thanacare as a digital platform to help make these care plans and to make them accessible so that in a moment of crisis, people can refer to these documents and have some sort of proof that this is what mom, dad, my sister, brother would have wanted. How does that work in terms of working with Thanacare to make sure that my wishes are documented and stored and accessible?
We bring up a very good point, and that is that even when the documents are done, they're not always available. If you work on, sometimes they'll do this through a lawyer. Vascular planning documents will be done along with the will. And if those documents aren't available when decisions need to be made for that patient in an emergency setting, then typically caregivers and have to go forward with all means, try to resuscitate that patient. And so what we're trying to do is not only ensure that the documents are done, but make sure that they're available. We interface with the healthcare systems and the electronic health record to try to digitize the information into their electronic health record. We give them a little card with a QR code that can launch those documents. And we have a magnet version that can be on the refrigerator. The point you bring up is a good one. And we see that routinely. And that is, if you don't have documentation and you collapse at home and you've not given any instructions to your family members, and there's no ability for the electronic or the emergency responders to understand what the rules, what the DNR, DNI status are, the resuscitation will take place. And that resuscitation, often means chest compressions. And there's just innumerable examples of how traumatic chest compressions are in an older patient. They end up with multiple rib fractures, don't necessarily live more than a few extra hours, and those kinds of things that really don't make sense. If we're doing a major intervention that leaves a patient traumatized with multiple rib fractures, and the only thing that they gain is a few extra hours, most of the time that patient, if you ask them ahead of time, would that be something you'd want to have done at end of life? The answer would be no. Let me go in peace. It's important to do the documentation, and it's equally important to make sure that documentation is available to the healthcare providers managing that patient's journey, because they need that legal documentation in order to make those decisions. And if it's not available, it's like not having.
Is it true or not true? A patient doesn't have to visit or receive care at the same hospital if they're in a different state. Are those documents still accessible in other healthcare systems?
Yes, and the answer is they can be. So most of the time, if each state has their own specific rules, we follow all 50 states' rules with regards to vascular planning documentation. Most patients, if they live in one state and we're from Minnesota. So in Minnesota, the people who are fortunate enough to be able to get out of here in the winter are this quote unquote snowbirds. Typically in Minnesota, they're either going to Florida or they're going to Arizona. And so what we can do is make sure that the documents that we have completed for them are meeting the criteria associated with both Florida and or Arizona, wherever they go. So we're able to ensure that what we are seeing is that the QR code, if the providers launch that and they can launch that, then they're most of the time they're more than willing to accept the legitimacy of that advanced care planning. And so we've not seen to date a lot of issues with ensuring that the documents are available, but it really does take an effort to ensure that that's the case. We really do, so we work closely with the patient's providers. We work closely with their primary healthcare system, and we work with the patient and their family to make sure that everybody has documentation so that they can access it easily if they needed to in an emergency setting.
Once again, I hear planning as a key theme in all of what we're talking about. Planning for when you're going to be visiting a different state, planning for a potential crisis, and it does give people an opportunity to have some control over the uncontrollable.
Definitely. And the planning it's not an overwhelming amount of planning. I mean, we have a digital platform. We do this almost always remotely on Zoom or Teams. Some of our older patients aren't that familiar with Zoom or Teams, but their kids typically are. And so we were able to navigate that. It's most often 2 45-minute sessions to complete the documents. And then we often will check in on them once a year for 30 minutes. Sometimes we instruct them if there's been a significant change in their healthcare status to call us so that we can update the documents. So there is planning involved, but it isn't an overwhelming amount of work. And what we have seen so far is that it's really been a very healthful exercise for the patient and their family. Once they break through and are willing to open up and talk about it, we kind of appreciate the opportunity to express what they would like and what they wouldn't like. It's clarifying for the family. I think the family enjoys having the knowledge of what to do for mom or dad. And I think that it works well. It's been an interesting experience. We found there are certain cultures that not only is there the inherent fear of death that's present in every culture, but there are certain cultures where they believe if you talk about death, it's more likely to happen. I mean, we probably see this most notably in the Hispanic patient population. That's a real cultural barrier here, and we have to try to break through that. And then there are some cultures and peoples are, for a variety of reasons, are distrustful of the healthcare system. Any discussion about less care kind of feeds into that distrust that while you're just trying to not deliver care, because it costs. Being a practicing physician, I know there are always going to be exceptions to the rule, but I just don't see that. And I think what we want to do is deliver care that makes sense and try to avoid exposing our patients and their families to anything that we wouldn't want to expose our patient, ourselves or our families to. And, I think we're still, fortunate to have a number of people who work in healthcare who are centered ethically and would hope to be in the best interest of their patients and their families. So I think that, but these things are real. These kind of situations need to be worked through, but there are so many benefits to planning ahead of time. And we generally, this could be done at any time that somebody's an adult, but we're currently focusing on those patients primarily in the Medicare patient population, the 60 or older, because they are statistically most likely to have to make some of these decisions at some point. But I wouldn't push that. If somebody was 30 and they said they wanted to do their advanced care planning, that's a very responsible thing to do.
Where do you see long-term Thanacare fitting into the larger ecosystem of personalized care?
I would answer that question by saying that we're not the only ones who've identified a problem here, with regard to the lack of planning in terms of end-of-life experience. Our commitment in Thanacare is to try and help as many people as we can to do better, to get the documents done, because we know that they and their families will benefit from the better, more graceful end-of-life experience and less family conflict to follow that end-of-life experience and less unnecessary financial harm and emotional harm. And so the process of digitizing advanced care planning documents is actually relatively new. When we started that here 5 years ago in the state of Minnesota, most of the documents were still paper documents, believe it or not. Not only were they were paper, they ended up in a file, and they often stayed in a file and weren't available at the time when patients needed them. Now, almost everybody has an electronic health record. And so we know that as we get the documents done, we can incorporate those into that electronic health record. But even if that patient happens to be outside of a hospital and needs resuscitation, if the documents are done, that has the QR code on there to launch that. So we feel confident, and we've seen that the patients can reliably transmit that information to the people trying to make decisions on their care. Everything's digitized these days, so that's not that surprising or revolutionary. I think the biggest thing is just trying to get through to people and understand that, guess what? Put aside your fear of death for a little while and talk about it, because it's going to happen. We all die. None of us want to think about it. It happens to every one of us. And it's a big part of it's a big transition for ourselves, obviously, and our families. And it's a gift to your family. That's the message we try to make. It's a gift to your family to plan ahead. It's a gift emotionally. It's a gift in terms of unburdening them. And it's just the right thing to do. When we do it all on remote Zoom and Teams, people don't have to leave their home. They can be at home. They don't even have to be at home with their child. It could be multiple people on the same call in different settings. So it's very convenient to get the documents done in that regard. They're not having to go to a doctor's office or a lawyer's office. And so that convenience is important to people and helps us increase our adoption rates. But still have to get them over that hurdle where they see what the problems are, and they understand, and they want to avoid those problems.
I've heard many people say, as apprehensive as they were to complete documents, that they really felt better after the fact. Kind of that's done. I don't have that burden on my shoulders. And I've heard that time and time again.
It's actually very true in our experience as well. The families are happy that they've got some guidance. It really is the form of a bonding experience. It's like, okay, this is how it's going to be. This is how it's going to go at end of life. Thank you for helping us in that way. Thank you for giving us the gift of letting us know with certainty what you want done and what you don't want done, and help make those decisions for you when you no longer can make them.
A lot of people think that once they make a decision, it's set in stone and they're unable to change their mind and wishes as time goes on. How does it work if I say at one point, no artificial nutrition or the limits of the interventions that I'd like? And then 6 months later or 2 years later, are people able to change their minds over time?
Yeah, definitely. I mean, the truth is that even if you do the documents, and who you define as your power of attorney, the person who will be making the decisions for you, if you find yourself in a situation where you're unable to make those decisions, that person, whoever that might be, they can kind of make their own decisions. But what ends up happening is that most of the time they will follow the rules. And most of the time they will do what you want them to do ahead of time. And they will not have the guilt of responsibility of making those decisions. And they won't have to face challenges from, for example, their brothers or sisters who disagree with the decisions that you made. And they might still face some of those challenges, but if it's documented what decisions you've made, then the medical sphere of it will not be as exposed. Let me put it that way, in terms of making decisions for you. We make a little video at the end of the process so that the patient basically can reaffirm that these are my decisions. This is what I want to see done. But it is also true that things change and patients' opinions change over time about what they want or don't want, and they can make those changes at any point in time. There's really significant flexibility in terms of making changes if needed. That's why we check in once a year, just to make sure that we kind of briefly revisit the conversation, it generally doesn't take more than a half an hour. Oh, are things the same? These are your wishes. This is your medical power of attorney. Is this all accurate? And most of the time, the answer is yes. Sometimes the answer is no, you know what? I'd like to change this or that. And then we make those changes.
Before I ask my final question, I want to make sure that we're clear on what advanced care planning is for. It's in the event a patient cannot make their wishes known. Is that correct?
Yes, that's my interpretation of it. It's like if a patient's able to make their own decisions, for them, they get to make those decisions. That's never going to be brought into question. Now, they may not make good decisions, but they're still their decisions to. And advanced care planning is primarily a documentation process to document what you would like to see done in the event of you being unable to make those decisions for yourself. And so that means that you have to define an individual or two, typically, not six often. I mean, it's going to be your spouse and or a child or two who are going to be defined as your medical surrogate. And then if you have these conversations, you ask a number of questions about, you mentioned to do not resuscitate, do not intubate. You talked about nutrition in the event that you're unable to eat, all of these antibiotics, all of these measures that could be taken to prolong your life. Do you want those done under certain circumstances? And again, most of the time, patients who are alive and in this situation are either in the hospital facing an emergency crisis or they're in a long-term care facility. The interesting thing about the end-of-life experience is that there aren't that many ways to die. I mean, there are 10 or 15 ways to die that define the endpoint for most of us. You can die from dementia, which is, I think, arguably one of the worst ways to die because you lose the ability to recognize yourself and your family members and your friends, and your body is still alive. And most of the time, those types of lives, by traditional measures, again, everybody has their own beliefs, and there are no right beliefs or wrong beliefs. But most people traditionally, when they're young and healthy, they would say, well, I don't really want anything done to prolong that life if I face myself, if I'm facing that situation. So if I get sick with pneumonia and I'm in a memory care unit, I'm not sure I want antibiotics, and so other patients, cancer deaths, organ system deaths from either heart failure or lung failure or kidney failure, there aren't that many ways. And what we see is that if you dig deeper into an individual patient's specific disease process, health concerns that they have, you can kind of add to the quality of the advanced care planning documents by answering specific questions that and helping them understand what that disease that they have might lead to. For example, with chronic obstructive pulmonary disease, often at the end point, the question is, do we put a breathing tube in? And yes or no. And again, if we put the breathing tube in, one of the concerns among treating providers is, can we get it out? Or are you just going to be living out of that? And I think that most of the time, if you get to that point where the real concern is we can intubate you and prolong your life for a few weeks, that you'll just be on a ventilator, unresponsive. Most people would say when they're young and healthy, no, I don't think that makes sense. I don't want to do that for a few weeks if that's all it means. Patients with end-stage renal disease, kidney disease, they often end up on dialysis. And that's not an easy life. I mean, you're on the dialysis machine 3 or 4 times a week for 4 or 5 hours. And, the majority of those patients after 12 or 18 months, they kind of say no more, if they can make those decisions. And then if they're mentally challenged by their end-stage renal disease, which some of these patients are, most of the time, I think if they were thinking about it ahead of time when they're young and healthy, they'd say, no, I don't want that to continue to take place. If it's not really going to prolong my life or make my remaining life better, I That's not what I would
Mm.
like.
So, in closing, I am a viewer. I've gained insight from the wisdom that you've shared today, and I'm prepared to put advanced care planning on my list of things to do. How can Thanacare help me get started? And what are your final words of wisdom?
You can go to Thanacare.com. We have a little box that you can click on to get your documents done. We'll be in contact with you and get it done. The cost of that is roughly $250. That will give you the documents completed, 2 45-minute sessions, and we will keep the information and ensure the information is transmitted to your treating providers. That cost is very close to our cost. You're going to have a nurse, social worker who's going to be calling you and conducting these sessions with you. So their labor costs associated with that represent the majority of that money. And we understand that that's not for everybody, but if you look at the big picture in terms of the value that you bring into yourself and for your end of life experience and to your family through diminished burden, emotional and financial, I think it makes perfect sense. We are working with healthcare systems and, quite frankly, insurance companies to try to get these documents done. We work with a number of not-for-profits, Jewish Family Services, for example, where they will sponsor some of the advanced care planning documents for the people inside of their organization. We work with other not-for-profits. We have pediatric palliative care relationships and other hospice and palliative care relationships where we try to interface with them to try to make sure that they can get the documents done. I think that the big picture message is it's the right thing to do. You only die once, and you want to die as well as you can. And I think by helping your family define who's going to make the decisions at the time that you can no longer make them, if you find yourself in that position, you will be giving them a gift of diminished burden, emotional. It's already going to be a very emotional transition for them with your passing, but you can make it easier by helping them understand what you want and would want is part of your end of life experience, and that they will be better off for it, and there will be less conflict. And quite frankly, often some of these hard-earned resources that you've worked your entire life for will be more likely the people you want them to go to, your spouse and your family, as opposed to paying for long-term care facility services that really haven't provided you a quality of life that you ever would have wanted ahead of time. We're able to make those decisions. So it's the right thing to do. I've done it. I've tried. Most of my family have done it at this point, and so I'm kind of a passionate zealot about trying to get people to understand why it's important.
All right. Well, Dr. Madison, thank you so much for sharing your experience, your knowledge, and things that you've noticed over the years, and having such courage to be a physician who is being honest and real about what healthcare crises can look like. I look forward to viewers being more educated on this topic.
Thank you. I really appreciate the opportunity to get the word out. Thanks so much.